So we are doing dose response curve in this module. So we are plotting dose on the x-axis and the response on the y-axis. So we are getting this kind of graph. Now why? Let's say we increase the dose initially, then the response is also increased, but at a level. Now from here, no matter how much dose I increase, the response will be same. Why? Because initially the enzymes or the receptors are all full, when the are all empty. When the drugs comes initially, the enzymes are getting filled. Now the number of the enzyme is limited, right? So no matter how much I increase the drug, the effect will be brought by only this much amount of enzyme, so response will be constant. So this type of curve is called dose response curve. The shape is hyperbola and it cannot compare two drugs. Why? Because there is no straight line. We need a graph which has straight line to compare two drugs. Done? And it's not used clinically. Now from this graph we are making log DRC. So in this log DRC, what's the difference is, on the x-axis we are having, in place of dose we are having log dose, but that's the difference. Response is same and it's a sigmoid shaped curve. Now you will tell me that this is also not a straight line. How will you compare? But see, here it is a straight line in this area. We are not interested what happens at low dose or what happens at high dose. Low dose does not cause effect, high dose will cause toxicity. So we'll obviously give in this dose only, right? So we are getting a straight line in this range, and this will be helpful to compare two graphs ahead, right? So the important parameters obtained from log DRs will be potency, efficacy and slope. We'll study it all in next slide. Now see, here are two drugs, drug A and drug B. Now if I want this much response or this much effect, the drug A is giving me it at a low dose, while B is taking a higher dose to produce the same response. So A is more potent and than B. So let's say if I wanna lower down BP from 180 to 120, then the drug A is taking 10 milligram, B is taking 20 milligram to do the same function. So A is less potent. So this was potency. So the curve which is on the left side is, left side curve will be more potent than the right side curve. Done. Left side here there will be more potent. Now efficacy is just the effect. We are just seeing the effect or the response. Let's say B is producing this much response while A is producing less. B is taking more dose, that doesn't matter. I just want a higher response. Whichever drug is making the higher response is more efficient, or it has more efficacy. So regardless of the dose we are seeing the efficacy. So now let's compare potency and efficacy. So for potency, I know the left side, whichever is taking low dose is more potent. So potent one will be D, then A, then B, and then C. Done. So the potency will go like this, and efficacy from top to down. C is producing the maximum response, so C, then A equals B, and the D at least. So clinically, efficacy is more important potency, because we are interested in how better or more response can be made. We don't care it is made at low dose or high dose. We want that our BP should fall to 120 from 180. I want this response. Now if a drug is not able to produce this response, it is useless for me no matter how low dose it is taking. I want this response. So efficacy is clinically more important. Now we are comparing efficacy and effectiveness. What's the difference between them? Let's say you bought a car. The ideal average which the company people say is 15, but the car when it's on a bad road or bad traffic, it will give 10, 11, 14 average, right? It won't be giving 15 average always. So this is efficacy. The efficacy is what? The functioning of a car in ideal condition. When the conditions are ideal, we call it efficacy, and when the conditions are real, we call it effectiveness. In the same way, let's say a drug A is tested on a patient in ideal condition, means we are carefully watching the patient, that he is having controlled diet, he is not having alcohol for any drug reactions or interactions. So in that environment, the drug A which was given will lower the blood pressure by 60. But in real day-to-day life, we won't be checking that patient, right? So he will be having mixed diet, he will be taking alcohol, and the interaction will be happen. So in the real day-to-day life, the same drug A will lower the blood pressure by 50, 45, or 55. In different person, it will lower it by different amount. Why? Because different person is different. In the same, in here the traffic was different, like bad road, weather condition, the average was different. In the same way, this drugs functioning will be different on different person. So this is effectiveness. So in log DRC, the curve we were measuring efficacy, not effectiveness. Only efficacy we were measuring. Done. So now let's understand the slope. What is slope? See, let's say this is a drug A and a drug B. I gave the drug A to person 1 and drug B to person 2. Two different persons are given these two drugs. So the dose is here and the response. What is the response? Response is CNS depression. Both these drug will cause CNS depression, but how? See, the low dose they are causing sedation. When the dose increases, they'll cause sleep, anesthesia, and finally coma. So the dangerous thing is here. So it's going away. Now, see, if I increase the dose, see, I want that my patient should get sleep, not coma, anesthesia. I want sedation or sleep in my patient. So here, see, the drug B will give me sedation at this dose, and drug A will give me sedation as low dose. So I should ideally use a drug. Why? Because I'm getting effect at low dose. But no, even if I increase the dose of drug A by this much amount, then it will shoot up and cause me coma. See, so it is not safe. While B, even if I increase the dose from here to here, it's never gonna cause coma. It will maximum induce more effect. So drug B is more safe than A. So slope represent what? Slope represents safety. The one which is flat is safe and the one which is steep is unsafe, because only a little bit of amount of dose increase, it will cause harmful effects. So this A was benzodiazepines and B was barbiturates. So obviously in the treatment of insomnia we use what? Barbiturates. Done. See, now we are understanding competitive and non-competitive inhibition. Let's say this is a drug A which acts on these four enzymes and the function or the effect is produced. Let's say this antihypertensive drug, and these enzymes will work and decrease the hypertension. So now I gave a competitive inhibitor to this drug A. Now what will happen? Some enzymes will bind with this drug while some enzymes will bind with these drugs. So the function or the response will decrease, right? In the next case, I'd give non-competitive inhibitors. Here also same thing will happen. The non-competitive inhibitor will make these two enzymes non-functional and these drugs will bind in these two enzymes and response will be made. So both the case response of the function is decreasing. Why? Because there is competition. But in the competitive inhibition, if I increase the dose of drug A, then all the enzymes will get this drug, and my effect or the response will increase when I increase the dose. But in case of non-competitive enzyme inhibition, these two enzymes are permanently gone, they are not functional. So even if I increase the dose of the drug, only two enzymes are there to make the function. So in the non-competitive inhibition, increasing the dose doesn't help. So in the same way, here we have, see, this A, this graph is without any antagonist, without competitive or non-competitive inhibitor, is the drug A. Now can you tell me what are B and C? See, in B the response is decreasing, so it is ideally non-competitive inhibitors which is making the enzymes non-functional and the response is decreasing. Whether in C, the response will be achieved as much, but we have to increase the dose. So B and C are with antagonist. C is what? C is shift to right, which is competitive, and B is shift to down, which is non-competitive antagonist. Now we see that in competitive antagonist, the potency decreases, means we need a more dose to get that response, while in non-competitive the response itself decreases, so there is a decrease in efficacy. Done. So all the dose response curve we studied till now were what? Graded DRC. What does graded DRC means? Means we are measuring the response in a single individual, that how much is the hypertension of that individual increasing. Either the person is getting, see, either the person is in sedation, sleep, anesthesia while increasing the dose. So it's all measured on a single individual. This is called graded DRC. In the upcoming we have quantal DRC. Quantal DRC is different. How? The quantity is plotted on y-axis. Let's say this is the y-axis. Here we have quantity. What quantity? Percentage of subjects responding. Let's say I gave a drug A to 100 mice. Now I will make a graph, and on the y-axis here I will have the number of graphs, like the number of mice which are showing me the effect. So in the y-axis I don't have a single mice, I have a percentage of subjects. So this is quantal DRC. We'll study about this experiment in the next slide. So here the response is measured among subjects. The dose of the drug is given in 100 mice and the response is measured. Now, important thing here to notice, the shape of both log DRC, the shape of quantal DRC and the graded DRC is same. They are both having the sigmoid curve. Okay, done. So now let's move on to that experiment that I told. Now, if I give a drug A to, let's say, 100 mice, now I want to see that at what dose all the mice dies, all the mice die, or let's say this, at this dose what is happening is we are getting effect in 50% of individual, means 50% of mice are showing response at this dose. This is TD50, and LD50 is the dose. We are increasing the dose, right? So LD50 is the dose at which 50% of mice are dead. So that is lethal dose. LD50 is the lethal dose. TD50 is where 50% of mice are getting some effect or some benefit. So TD50 is good for us, LD50 is bad for us. So from this experiment I will know that on what dose I am getting effect of a drug in 50% individual, and at what dose 50% of individuals are dying, right? So I'm getting the lethal dose also from this. So I made a ratio between this is LD50 divided by TD50, which is therapeutic index. Now what I want is my drug should have high LD50, means at high dose only it is lethal, and I want low TD50. Why? Because I want that at low dose my patients are getting effect. See, what I want is at very low dose the 50% of the individuals are getting the effect of this drug. So LD50 should be high, TD50 should be low. So the therapeutic index of a drug should always be high. Don't use narrow therapeutic index drugs, those are harmful. So therapeutic index is a safety margin. Done. So that's all for today.